One Australian dies from cardiovascular disease every 12 minutes. And yet, most people in their 40s and 50s, people who work hard, eat reasonably well, and actually care about their health, think they don't need to worry about this yet. Today's episode will change your mind about that. Today I'm talking to Dr. Jason Kaplan, integrative cardiologist and cardiac imaging specialist. He takes a holistic, preventative approach. In this episode, you'll learn the most important tests you should have in your 40s to assess risk factors, the dietary approach that best supports long-term heart health, and other important lifestyle factors that you may not have considered. Don't leave your heart health until you're facing critical problems. Listen today and find out the simple steps you can take now to prevent cardiovascular disease. Welcome to the show, Jason. I really appreciate you being here. I think that this is such an important topic. It's one that affects so many Australians. I know for myself, I never got to meet my grandfather because he died of a heart attack when my father was only 24. And I think most Australians would have some experience of heart disease somewhere in their connections. And so I think this lens that we're putting on today of prevention and starting early is so important. So I really appreciate you being here.
Thank you so much for having me.
Before we jump into the nuts and bolts of why we're here and the important discussion, I always like to give my audience a bit of a sense of the person that they're listening to. So I'd love to hear, how do you start your day? You obviously work at a very high level. How do you set yourself up for success and focus?
Look, I do start my day with a coffee with non-dairy milk, usually soy milk. We have three primary school age children at home and 2 dogs, so life is busy in our household. But generally, I'll spend a few minutes sitting outside with a cup of coffee, usually around sunrise or just before. Sometimes some morning stretches. Some mornings before work, I will go to an exercise group. We live near the beach, and I'll join a bunch of other people exercising, and sometimes go for a swim before work in the ocean all year round. And I find that quite invigorating and gets me set up for the day.
Beautiful. Yeah, you're hitting lots of boxes there with sunlight and community and exercise and everything. Beautiful. So let's jump in. Let's start with, I think heart disease is still seen as something that happens to older people or people who don't look after themselves. So what's the reality of what you're seeing in the clinic right now?
So that is the perception, but in reality, that's not quite the truth. Firstly, that the risk factors for developing heart disease, and I think it's important to define for most people, when we say heart disease in Australia, we think coronary artery disease. So this is the buildup of fibrofatty plaque in the blood supply to the heart called the coronary arteries. And the disease process is called atherosclerosis. And that is usually a combination of all of an individual's risk, including genetic risk, lifestyle risk, traditional cardiovascular risk factors such as cholesterol, blood pressure, diabetes, smoking, inactivity, obesity, and that all inflammation, and that all contributes to the development of disease in the arteries. But we know that those markers start earlier on and earlier than people think. So when someone presents with heart disease or a heart attack in their 50s and 60s, that has its origin in people's 40s or sometimes in their 30s. So although the clinical presentation of heart disease may be for some people older, those early markers and those risk factors are there from much earlier. So I do diagnose young people with early plaque in their arteries, early atherosclerosis, cardiovascular events before the age of 50 in men. So this is absolutely there, and I think it's not a disease just people get when they're older. Of course, people will get it. Some people will get it when they're older, but the underpinnings are there, often 20s, 30s, and 40s. And interestingly, Kelly, one of the most famous cardiologists in the world, his name is Valentin Fuster. He used to be the editor-in-chief of the Journal of American College of Cardiology. He's looking even earlier. And some of his early work thinks that some of our childhood dietary and lifestyle decisions impacts our cardiovascular health later in life.
It makes so much sense to me, but yeah, I think that to people that could be quite shocking that they actually need to be thinking about their heart health from 30s or even with their children, like you're saying. Okay, so let's dive in then, like what are the greatest risk factors for cardiovascular disease and how much of that is genetic versus lifestyle choices?
So that's an excellent question. So I always tell patients you cannot ignore your genetics, both your family history, and more we are now being able to look at people's genome. There are specific biochemical markers that help people think about their own cardiovascular risk. And there was a wonderful paper in the New England Journal of Medicine by Amit Kira, who is a preventive cardiologist in America, and he looked at people's underlying genetic risk and then the effects of positive lifestyle effects. So what the paper actually showed was if you had a high genetic risk, so you had lots of family members with heart disease or coronary artery disease, if your genetic risk was high, but you made positive lifestyle effects to, if you have a healthy weight, healthy dietary patterns, regular exercise, stop smoking, controlled blood pressure, you could reduce your genetic risk by around 50%. So not only did that patients reduce their risk, they also attenuated and stopped plaque building up in their arteries. So despite us having patients having a high genetic risk, your genes are not your destiny. You have to work hard at it. And I'm not saying that it is easy. And when I say control all those risk factors and lifestyle and exercise, it's easier said than done. And often in my practice, where I try to help people with this, how do we then implement those changes in their lifestyles? Because it's the daily habits or the ordinary that then make major changes. I don't think there are many people there's still some people that are smoking in Australia, and I always get concerned about seeing a lot of people now vaping, and I'm not sure that is all that much better for people, much better, and still carries a significant cardiovascular risk. And that is still one of the major risk factors for the development of early heart disease. We can't forget things like, the simple stuff like, high cholesterol is a very interesting one. And my patients always say, well, my cholesterol's high, but I've got time. But as what I mentioned, those underpinnings are there very early. And there are lots of studies that have been done in patients from 20 to 40 years old. And what it shows is that if you control those risk factors from 20 to 40 years of old, your chance of developing heart disease later in life are much, much less. Now, it doesn't mean you need medications. And for all my sort of younger patients and patients that we deem to be lower cardiovascular risk, and there are a few ways we look at that using risk calculators. What I try to do in my practice is personalize it for the patient in front of me using biomarkers. One of my interests is imaging subclinical disease, so we'll probably talk a bit about later about cardiac CT scans, but we can personalize it for the patient in front of you, and then usually in the first instance, lifestyle-directed therapies to reduce their risk.
Wow, so much gold there. I'm trying to hold it in my head and think, where do we go? I just want to underline, though, what you said about the 50%, because that's really important that people are hearing, that despite your genetics, you said, right, that 50% is about your lifestyle choices. That's
absolutely. So the people, really, in that study, it's a great study. That study that you had bad genetics and you had bad lifestyle choices, you were in real trouble. And a lot of those people had significant events. But the lifestyle choices improved cardiovascular health, reduced risk all throughout the underlying genetic risk spectrum. So I can't underscore the importance of making those changes earlier on in the life cycle.
Okay, I want to dive into all of those, but maybe we can step something else that you said, which was around like testing, and let's start with genetics. Is it just knowing your family history, or do you recommend people having their DNA done? What's your recommendation?
Look, great question. So family history is very important. There are in research tools and in lots of studies being done what's called a polygenic risk score, which are a whole bunch of genetic markers that allow sort of closer correlation of cardiovascular risk, though those are not being used in routine clinical practice. So what I would do routinely is we get people's traditional risk factors, a cholesterol test. So there's a new emerging risk marker. Well, it's not emerging, it's been around for many years, though it's coming to prominence, called lipoprotein A, and that is a genetically inherited lipoprotein in people's blood. And essentially, it causes accelerated plaque formation in arteries. It can cause accelerated aortic valve disease and also carries an increased risk for blood clotting in people's arteries. So generally now we would recommend screening with this protein called lipoprotein A at least once in someone's life cycle. And if elevated, it confers an increased cardiovascular risk and usually puts someone up a risk category. One of the key cardiovascular testing that over the last 20 years has really emerged to help risk stratify patients is a coronary artery calcium score.
I was going to ask you about that.
We are, as a group of physicians in Australia, we are lobbying hard that this becomes a Medicare rebated test. Currently, it's not, though anyone can request it, and it's not all that expensive. It should only be around $100, and most large radiology practices can offer it, and most GPs can order it as well. And this tells us about it's purely a score of long-term atherosclerotic plaque. And if you're a man in your 40s with multiple risk factors, it's certainly something that you should get. Or if you're a woman around 50 or menopause, it is a test worth getting as a screening test, and then allows you to compare with other patients of similar ethnicity, age, and sex. And we have wonderful studies that clearly provide guidance about how best to manage various levels of scores. And then I would integrate it into a clinical risk score. And there are great calculators that do that. Something called, people interested, called the multi-ethnic study of atherosclerosis, or the MESA risk calculator, that integrates traditional risk scores with the coronary artery calcium score. The gold standard, and what now we have the ability to do, we can do what's called a cardiac CT scan. So that is just the calcium score, the dose of radiation is very small. It's the equivalent of about 3 to 4 chest x-rays. So it's a very low radiation test. It doesn't involve intravenous contrast. The gold standard test is called a CT coronary angiogram. That's a little bit more involved. You do need to get intravenous contrast. It's a slightly more expensive test, slightly higher radiation dose, though that visualizes the degree of narrowing in people's arteries and what we call non-calcified plaque. Now, why that is important is there are certain, when we look at plaque in people's arteries, not all plaque is equal. There is some plaque that is stable plaque, and that's okay. But we are now able to identify high-risk plaque, and that high-risk plaque are basically heart attacks waiting to happen.
Right.
So that allows us to target therapies and make decisions based on prevention, based on what we're actually directly seeing in the artery. So while people may have risk factors, in a way, the proof of the pudding is what is going on in the arteries. And I just want to share a story. When I was doing I did cardiology fellowship at Royal Prince Alfred Hospital, and I was training there, and we dealt with, during your fellowship and training, you deal with a lot of sick people who are, in the middle of the night, getting up, opening up people's arteries, dealing people with the worst end of heart disease. And I started realizing we're getting people at the very end of their course. We got to try and get people way before in their journey, which led me into the field of preventative cardiology. And what really hit home was one of my consultants working there, he was a very fit man in his late 40s, but had a family history, and he exercised, he was running. And then one night running, he started feeling some chest pain, and he basically had a cardiac arrest. And sadly, he passed away, and he had undiagnosed coronary artery disease. Right. And a simple cardiac CT scan done a week before what was happening would have, prevented that, prevented those events. So these tests are very powerful.
So of the 3 tests that you've mentioned, do you recommend doing like all of them at once in order? Could you just talk me through that? And what's the procedure? Like, can you get these recommended from your doctor? I know I've had the calcium artery score because of the family history. I did it earlier than you said. Just if you just go over with those 3 tests, kind of the order that you'd recommend, how people would go about ordering one, and just again cap on the ages and so forth. That would be really helpful.
So look, firstly, I think, patient's primary care doctor can order most of the bloods, including lipoprotein (a) and a cholesterol panel. I do sort of recommend getting a blood marker called ApoB. ApoB is a slightly more accurate marker of all of the potential cholesterol lowering particles in someone's bloodstream. You can't ignore the simple things. So, look at blood sugar levels as well. Get your blood pressure. Get the basics, first. Then, as a screening tool, I think it's very reasonable for men of the age of 40 to have either a calcium score or a cardiac CT, probably a cardiac CT scan over the age of 45 for women around menopause. As long as you understand, the risks of having a radiological procedure, which are very low, and then that can lead on to further testing. So generally start with the blood work first, a proper risk analysis by a primary care physician, and then to help risk stratify someone and help direct therapy, then what we call more advanced testing of atherosclerosis or plaque.
Okay, perfect. That's really clear. And I think that story that you told, I actually know a similar story from a friend's husband. So yes, so important, early testing. I think, we have a data company. It's all about, if you know your data, you can take action. If you don't, you're operating blind. Let's go back now then to those lifestyle factors, and maybe we could unpack them one by one, kind of the key ones.
Right.
Let's start with, I saw that in 2022, the American Heart Association updated the cardiovascular health checklist and added short sleep duration as an official risk factor for the first time. So I'd love to kind of hear, why does how long we sleep actually matter for your heart? And I have some people very important in my life who have very short sleep. So personally motivated to get this information.
So, what has been really, more and more we are learning that both, the quality of sleep and sleep duration have an association with heart disease. And I think it is wonderful that the American Heart Association now includes sleep as part of, they call it Life's Essential. It used to be Life's Essential 7, now it's Life's Essential 8, including sleep, which we know is a key cardiovascular metric. We know a number of things about sleep, that, reduced sleep duration, so less than 6 hours of sleep a night, is associated with an increased incidence of cardiovascular disease. We also know that interrupted sleep is certainly problematic. So interestingly, if you have more than, say, 8 or 9 hours a night, it doesn't really help from a cardiovascular risk profile. Poor sleep habits then also lead to downstream both behavioral issues, lifestyle issues, and neurohormonal issues. So we know how important sleep is becoming, and for anyone who's really interested in trying to take care of their cardiovascular health, that sleep metric is very important. We also know that people who are overweight, who snore, may be predisposed to a condition called obstructive sleep apnea. And obstructive sleep apnea is, besides the way it makes you feel in terms of tiredness and feel like falling asleep during the daytime and other symptoms, it is associated with the increased risk of heart disease and particularly high blood pressure. So often my patients, when they have sleep apnea, and everyone's heard about the continuous positive pressure masks that people use, or some people need a mouth device, those interventions can make a big difference. But also weight loss, patients that can lose around 15% of their body weight with weight loss also make a significant improvement of sleep apnea. Now, it's fine for us to say that sleep is, that addressing sleep is important, but what the challenge is, and I don't think there's an easy answer, is making those changes. How do we do that? And those are broader lifestyle changes. Sleep hygiene, getting rid of technology a few hours before bed, often changing the quality of the light that we're exposed to. Those are not easy changes to make, and often people's sleep habits have taken years to form.
But I think it starts with the mindset, because there is, especially amongst high achievers, which my audience are, this kind of attitude that, like, I have too much to do, I'm too busy, and everything else will go first. So I think it's really important to hear very clearly how the evidence shows that sleep is critical for your health.
And often I know for myself that, having a bit more sleep allows my brain to function. For a high achiever, allows your brain to function better as well.
Definitely. Absolutely. I feel completely like my IQ plummets of any less than 6 hours. So definitely. Let's talk about cholesterol, because there is a lot of noise about different things to do and so forth. And so just to get your perspective on that.
Great. So look, there is a lot of noise about cholesterol and diets. One of the big things that comes up in my preventive practice, every day. So firstly, I think the important thing is I tell my patients is that the development of heart disease is not just about cholesterol. Not everyone with high cholesterol develops heart disease, though it certainly is a risk factor. And when I think we should talk about high cholesterol in the setting of someone who hasn't had an event, someone who hasn't had a heart attack, a stroke, needed a stent, because secondary prevention, someone who's already had an event, there's one of the best correlated, relationships in cardiovascular medicine is that if you've had a heart attack, if you've got coronary artery disease, achieving a lower, more plaque-forming cholesterol level, and usually this is manifested as LDL, but I talked before about ApoB, the better you're going to do. But we also know the same often lies in primary, people trying to prevent heart disease. Now, at some point, and goes back to why we screen people with cardiac CT or coronary calcium scores. At some point, after many years of exposure to elevated cholesterol levels in the blood, the body says, I've had enough, and I'm going to start depositing in the arteries. And it's not just in the arteries in the heart, that we know that early plaque formation occurs in sometimes the femoral artery, in men, in women, often it's the carotid artery. But our arterial system is this complex network of kilometers of small blood vessels as well that can all be diseased. So cholesterol is important, and we talk about it a lot because it's a modifiable risk factor. We have reliable both dietary interventions, some supplement interventions, some lifestyle interventions, but also medical interventions that can significantly reduce cholesterol and we know can reduce risk. And also, this is a really important point, that if you do have plaque or atherosclerosis in your arteries, we know we can achieve regression. So this is, reversing plaque in the arteries by achieving much lower cholesterol levels. And that biologically, we've proven that on multiple, studies when we put ultrasound catheters into people's arteries. So that doesn't happen unless the levels are low, and this is often what we aim for people at elevated risk. So it does play an important part of cardiovascular health, but there are many ways to address it. And usually in my patient cohort, lifestyle is number one. Lifestyle, diet, number one factors about
Okay.
dealing with it.
Could
And
you talk to me a little about that, the diet?
yeah, so diet is diet. There's so much about diet on the internet, on social media, and I tell my patients, please don't follow the fad. Let's follow the evidence, right? And when I talk about diet to my patients, I'm not just interested in what may make the numbers look good, or there are some diets that may be very good for weight loss or muscle gain, but you never want to mortgage your cardiovascular health, your cardiovascular health for those dietary patterns, because a very unhealthy, high fat, high protein diet can, there's people, I've had patients come on a carnivore type diet, they will run into problems later in life. So the dietary pattern that has the most amount of evidence in terms of not only having effects on biomarkers, our cholesterol levels, perhaps reducing plaque in the arteries, is a PESCO-Mediterranean style diet. And there are variations of that, something called the DASH diet. But that dietary pattern has been well studied. The key seminal study was the PREDIMED study, published in the New England Journal of Medicine in 2013, and we looked at sort of around 2018, that it included a high amount of extra virgin olive oil, a lot of whole grains, some fermented dairy, a reasonable amount of fish, plenty of legumes, high amount of fruit and vegetables. But then what was really interesting was the more plant-based you made that Mediterranean diet, the better patients did. The better their markers of cholesterol lowered on a plant-forward Mediterranean-style diet. So that looked replacing animal protein with plant protein and using a lot more plant-based sources, things including large amounts of legumes in your diet. Interestingly, there was a study called the Green Mediterranean Diet that used very high protein. It's called, I think, duckweed, or they sometimes call them water lentils, but they're very high in protein and B12, which often can be. You have to think about supplementing if you're on a mostly plant-based diet,
Yeah.
and that led to improvements in biomarkers. So the dietary pattern is important, and I think I love this movement, and we're not quite there yet in Australia, but in America it's called food is medicine.
Yes,
And
100%.
one of the most amazing things is this. There's now almost bringing programs into hospitals where hospital food is generally awful.
Oh, it's atrocious.
It's atrocious. Right? And one of my projects is think, well, how about patients that are like healing, that need to get better, and patients on the cardiology ward in the hospitals where I work, I look at their diets, look what they get served. I think this is just absolutely awful. How about giving people nutritious plant-based food to help their healing and start their process about the dietary pattern that they need to start eating to keep their hearts in check. And besides food as medicine, and we know that patients who have high, I didn't mention about inflammation, which is such an important factor as well. And in fact, the American College of Cardiology published a position statement on this last year that residual inflammation, either from certain disease processes or lifestyle choices, carries a cardiovascular risk. And we know that in someone, even if their cholesterol is well treated, targeting residual inflammation risk is very important. And there's certainly plenty of things that people can do with use an anti-inflammatory diet pattern as well. Herbs and things that people can use, things like turmeric, ginger, garlic, including lots of but they're anti-inflammatory dietary patterns. Food in a way is biological information. In fact, it's one of the most important choices that we can make. I firmly believe, besides giving up smoking and vaping, choosing a mostly plant forward diet is one of the best interventions that people can make younger in life to set them up for reduced cardiovascular later in life. And it's not just the heart disease risk, it's cancer risk as well. because
100%.
they are bimodal. Patients with heart disease develop cancer, or patients with cancer, the next biggest killing. Once you've survived cancer, you develop people develop heart disease. In the previous, before I did cardiology, I spent 2 years doing cancer medicine, and then now I'm fortunate enough I work with a great group of oncologists and hematologists at Royal North Shore Hospital, and we address cardiovascular risks in patients that are cancer survivors. And it is very, it's very satisfying work that we get people through cancer therapy, and then we prevent, further cardiovascular events after that big journey.
Yeah, absolutely. Um, I agree so much in terms of diet and food being medicine and not following these really rigid diets. You mentioned protein. Is there some kind of recommendation then on the kind of, because there's always recommendations on how much protein to make sure you get adequate amount, but are you saying there's also a cap, like too much? Where would that be?
Look, I think that a lot of your listeners may have read some of Peter Attia's work, Outlive, and I know that there's there's a big trend at the moment. Everything is high protein, protein added, a lot of dairy foods, a lot of foods are being fortified with protein. I one of the studies when I give talks is there's a great slide that I showed people about choosing to replace around 10% of animal protein consumption with plant-based protein options. And when people do that, that is significant. And you follow this group that was done on the nurses' health study and the physicians' health study, both long-term epidemiological studies done in the United States. They showed that doing that made a significant difference in terms of both cancer and cardiovascular outcomes. The number, I don't tend to put a number on it because it often depends on any individual's, training goals, what they want to do in terms of exercise, what they want to do with, in terms of muscle building or strength building. And that I sort of believe that should be individualized. But I do strongly recommend that, if patients do choose more plant-based protein sources. And believe me, it's easy. Those are easier to get than people think. Certainly plenty of legumes. You can get, some of those water lentils, spirulina, quinoa, black beans. One of my, people that are really interested in plant-based eating, I suggest they read some of the work of Dr. Michael Greger, and he wrote this great book called How Not to Die, and there's How Not to Die meal plans, but he talks about Greger's daily dozen, and we've got to include legumes and as part of our our daily food. What we do now is we, at home for morning smoothies, we freeze cannellini beans and we put them in our smoothies as good plant-based protein sources rather than using processed protein powder. We put them in the kids' smoothies as well, and they're getting their plant-based protein.
Nice, I love it. Yeah, with kids, you've got to sneak it in somehow.
You got to
Right?
sneak it in.
Totally. And just a second, nearly finished. I just want to touch on exercise before we run out of time, because I know you've worked with elite athletes. What's the balance? Because is there too much exercise, and what's the right type of exercise and the right balance for heart health?
So that is great questioning. I just want to preface before we start is that cardiorespiratory fitness over the age of 50, and particularly over the age of 60, is probably the best cardiovascular metric of longevity and reduction in cardiovascular events. So if I have a patient in front of me, I say to them, I want you to be in the fittest 20% of people of your age group. And in a way, it doesn't matter how they get there, because the heart doesn't really tell the difference between, say, rowing versus cycling versus running versus swimming. Though working with athletes, I can tell you that the heart adapts in certain different ways to different forms of exercise. And often in elite athletes, we see some of the most athletic and efficient hearts in long-term cyclists and long-term rowers. But the heart, for most people that are not, professional athletes, anything that you do to improve cardiorespiratory fitness will make a difference. And there's a very clear relationship between, even if you have heart disease risk factors, that the fitter you are, the lower your chance of events. Some of this work comes out of the Cooper Clinic in Texas, in America as well. So that primary thing should override, be one of the key guiding principles. There does come a point, though, when the cardiovascular effects of exercise starts to attenuate. So when you go more than around, say, 300 minutes of high intensity exercise a week, the cardiovascular effect starts to attenuate. So reduce your risk, but it's slightly a U-shaped curve. There is still benefit, but the absolute benefit is not as great. And so at a minimum, I tell patients, 75 to 90 minutes of sort of a high intensity exercise. That may be HIIT workouts, or where they're really getting their heart rate, between 70 to 85% of maximal heart rate, or at least over around 300 minutes of moderate intensity exercise. There is situations, and I'm sure that you speak to people, and I speak to people, where they really push their bodies pretty hard. Yeah. And they do a lot of high intensity exercise, and overall, while it may improve their fitness, it may have other sort of detrimental factors, including, adrenal exhaustion, or may not be, they just be tiring things out. And I encourage patients to do a combination of, call them yin and the yang. The yang is a very high intensity, but includes some yin exercise, something like yoga or tai chi or qigong, or a meditative practice to balance that out. Where I see, and particularly relevant to your audience, is where we see people run into problems if they really push beyond their limits. So, for example, doing there's a long distance running has had a renaissance, and I think we're lucky that Sydney now has, one of the biggest marathons in the world. But for people that are just getting into this, if they're not properly trained, and during competitive racing that their heart rates are particularly sustained, or their heart's under stress, those long periods of time under stress can predispose to subtle damage and scarring. And we know, we've seen that. We've looked at people who've done ultra marathons and examined their hearts and done blood markers straight afterwards. We do see very subtle damage. Paradoxically, there is also, for people that often do a lot of endurance work, in a predisposed person, they can develop high amounts of plaque in their arteries. Now, we don't yet know the significance about that. Also, patients who do a lot of people do a lot of endurance exercise, so usually more than 5,000 hours, which is a lot, but that's normal. You increase your chance of incident atrial fibrillation, which is an arrhythmia, by about threefold. So there is such thing as too much, but the broad principle is, that the fitter you are in terms of cardiorespiratory fitness, the longer you're going to live and lower your chance of events.
Yeah. And is it important that people, as well as like your zone 2 and your weightlifting, that you're getting your heart rate up to its maximum? So like a little bit of HIIT training, for example?
Yeah, I think that is one of, the best ways of improving cardiovascular fitness. And I think, a good, HIIT session is very beneficial for a lot of patients as well.
Yeah. Note that to self. This has been so useful, so interesting, and so many points for people to follow. I always like to end by bringing it down to one thing. So for the listeners right now, before they see their doctor, before they do anything, what's the number one habit that you'd recommend that people take on now in order for long-term heart health?
I'm going to preface that by one other thing, because it's not just one thing.
Yes, I know.
So there are superfoods, but not one superfood is going to make a difference, right? You can't supplement poor lifestyle choices. And we didn't get into supplements, but most of the supplements that people try to take for heart health have not a lot of evidence. So we look at lifestyle patterns. And I think if people are interested to think about something like the blue zones, is very interesting to look at. But for patients, under the age of 50, I would say that adopting a more plant-forward diet, and getting into those habits is one of the most important things that they can start doing. And it doesn't have to be all the way. It can be, some of the way, or even just replacing 10% of animal protein with plant protein. Just start small, make those small changes. Start learning how to cook a great legume dish, or start introducing beans into your diet, or plant protein sources. And then, start to develop a regular exercise habit, and how you can do that reliably and stay motivated. I know for me, I think groups are very motivating. When you're exercising with a whole bunch of people on the beach, it's spurs me on. So I think there are the key changes but also on the last point, that if you haven't had a proper cardiovascular risk assessment and you're in your 40s or 50s, please go to your primary care doctor and get them done. Get an idea of your there's plenty of online calculators as well. You can plug your numbers in and get an idea of risk. But please go, I sort of see that a lot of heart attacks that happen, we look after in the hospital, there was a chance for prevention there. And I'm passionate about being able to, prevent those events before they happen.
I think it's so critical. And I really hope that everybody listening to this episode will hear that and will go out and book those assessments. Mm-hmm. And hopefully from this episode, who knows, we might be able to help prevent something. That's always the hope. How can people find out about your work, and what are the ways to work with you?
So look, I consult in Sydney's Central Business District, as well as St Vincent's Clinic, and also at the North Shore Health Hub on the North Shore campus. I have a website, drjasonkaplan.com, that has all the information, and I work with two great practices: New South Wales Cardiology, based at St Vincent's, and Envira Heart Care, based at St Leonard's. And they can just look at those, get those details.
Beautiful. Thank you so much for your time. I really, really appreciate it.
Thank you.
Now it's your turn. Take what you've learned today and put it into action. Try the habit, run the experiment, and actually track how you go. I'll be doing it right alongside you and sharing on socials, so come find me there. Links are in the show notes. Tell me what's working, what isn't, and what questions are coming up. I genuinely want to know. And if today's episode helped, share it with someone who needs it. And if you haven't already, hit subscribe so we can keep optimizing our health together, one simple step at a time. Take care, and I'll see you next week.